In the previous section, we presented a case study of a patient who was diagnosed with COPD. Our continuing conversation will now focus on the management of patients with COPD. Dr. MacIntyre, in the previous section, we presented a case study of a patient who was diagnosed with COPD. What principles of medication management should we consider when treating this patient?
Well, Ben, fortunately, there's some really good guidelines out there. I think the ones that are quoted the most widely go back to our GOLD group, the Global Obstructive Lung Disease group. And they have proposed what I consider a very logical, stepwise approach to the management of COPD. So in the very mild forms of the disease, there are two key principles: smoking or prevention of further disease with smoking cessation and appropriate vaccinations. And the second thing is, if they do have intermittent symptoms, PRN or rescue inhaler with either a short-acting beta agonist or a short-acting antimuscarinic, or maybe a combination, is all that's really required. We get into the moderate disease, the stage 2 disease. These patients are now tending to have more persistent symptoms. They're using their rescue inhalers more frequently. And now it's time to move into long-acting bronchodilator regimens. You get into stage 3, now we have a patient who is not controlled with a simple long-acting bronchodilator, and now we're usually adding inhaled corticosteroids, and now we start thinking about things like pulmonary rehabilitation. And then in stage 4, of course, the most severe forms of the disease, all these medications, the long-acting bronchodilators, the inhaled corticosteroids, these patients are often requiring oxygen, and we actually have to start thinking of other more dramatic treatments, the very severe, for instance, lung transplantation. A caveat to all these is that if there are frequent exacerbations along the way, regardless of your stage, there's growing evidence that either inhaled corticosteroids could be added earlier. There's some new drugs we'll talk about later that we might add along the way. And also, regardless of your stage, if oxygen becomes an issue, and it can, oxygen therapy, usually for saturations, resting saturations, or exercise or sleep desaturations below 88%.
So based on these guidelines, what do you believe would be the best option to improve this patient's symptoms and slow her condition progression?
Yeah. Well, according to these guidelines, as we've discussed before, she's a moderate or stage 2 COPD patient. She's got an FEV1 of 52% predicted with the low FEV1 vital capacity ratio. So she fits stage 2 in the COPD guidelines. Now, looking at those guidelines, that means we've got to really focus on her smoking cessation. I tell my patients with COPD who are smokers, I say, first thing you got to do to get out of a hole is to stop digging. And they have to think about that for a minute, and they, oh yeah. Vaccinations, as we already talked about, are critical. We would certainly prescribe her a short-acting bronchodilator to use as a rescue or a PRN use. And this could be a short-acting beta agonist, this could be a short-acting antimuscarinic, or a lot of people like to use the combination of the two. So she also, because she's stage 2, likely would benefit from adding a long-acting bronchodilator as well. There are two types of long-acting bronchodilators or classes. There's what's called a LABA, L-A-B-A, which is a long-acting beta agonist, and this is usually a BID medication. And then long-acting antimuscarinic agents, LAMAs, L-A-M-A-S, LAMAs. And these are usually available as a once-a-day preparation. You can add, or you can start either one of them first. The guidelines are not clear or do not specify which one ought to be started first. I think a lot of people like the long-acting antimuscarinics because it's a once-a-day preparation, but they're both reasonable to start. If the original medication or the initial one doesn't control them well, they're still using a lot of rescue inhalers, then you can add the second class of long-acting agents.
So what else would be a reasonable long-term treatment strategy for her?
Yeah, she's stage 2. The guidelines don't usually call for it until stage 3, but I'm going to give you my prejudice is that adding pulmonary rehabilitation is really important. These programs are structured programs that focus on education and exercise and learning about how to manage their disease. And these programs are shown to reduce symptoms, reduce exacerbations, and actually improve what patients can do. Also, if the patient is a frequent exacerbator, And we define exacerbations as the need for episodic antibiotics or steroids or ER visits or hospitalizations. There's some other options. I already touched on this a moment ago, the addition of an inhaled corticosteroid. And then the latest sort of kid on the block is a new class of drugs for patients who exacerbate frequently, the phosphodiesterase 4 inhibitors, which are designed to modulate airway inflammation, and at least in clinical trials suggest that you can reduce exacerbations in, well, what we often call the frequent flyers. So that's another option to consider as we're going up the stepwise therapy in her. One other point about her, and I touched on this a little while ago, is that her saturation of 89% at rest is kind of worrisome. And this lady, if she desaturates further with exercise, or you find out she desaturates with sleep, most authorities would agree, by that I mean below 88%, most authorities would agree that that probably would qualify her for oxygen therapy as well. It's really critical that we have the right diagnosis, because this sequence of, or stepwise sequence, is different than it is in asthma.
Can you explain that a little bit more?
Yeah, this is important because in asthma, there are similar stepwise guidelines. In other words, you start off with just rescue medications, and if you have poor control, you keep adding additional medications. But in asthma, it is critical that the first step up is an inhaled corticosteroid to quiet the inflammatory response and prevent asthma attacks. And that's different than COPD. That's different than COPD. In COPD, we're recommending, GOLD is recommending adding long-acting beta agonists or long-acting antimuscarinics first, and then the steroids come later.
Okay, so let's continue the case for a second here. So Ms. W was started on a daily inhaled LAMA and a rescue short-acting bronchodilator. And after discussion of the risks and benefits of her smoking cessation and weight loss, she decides to start varenicline and attempt a diet and exercise weight loss regimen. So at this point, should we consider a change in any of her other medications?
Well, you're off to a good start. You're following the guidelines, beginning the right medications. I think rather than confuse the medication regimen unnecessarily, it's reasonable to see how this works. Does she feel better? Does she use her rescue inhalers less? Are there any issues of exacerbations? And if everything's kind of calm and looks like things are under control, we're probably doing okay right now. I'll throw in my prejudice I mentioned a moment ago. Even though she's only stage 2, I still think a rehab program would be appropriate for her. And further step up in the GOLD guidelines, I think, would be driven by her response to this initial appropriate first step.
Okay. You mentioned earlier that exacerbations are major cost drivers. Can you please explain a little bit about these exacerbations?
Yeah, I'm glad you brought that up, because exacerbations, as I mentioned earlier, are the #1 driver of costs in COPD. What are exacerbations? They're acute inflammatory processes that occur in the setting of COPD. They almost always are related to infection, often beginning as a viral infection, but often getting complicated with bacterial superinfection. So it's a worsening of their stable state, COPD exacerbations. And symptoms include anything from increased breathlessness, cough, increased sputum production, change in the quality or the color of their sputum. And these are often accompanied by increases in their rescue inhalers, and they're often increased by increases in oxygen requirements if these patients happen to be on oxygen. Recognizing these exacerbations are critically important, and preventing these exacerbations are critically important.
So what are the indications for antibiotic use in patients with these acute exacerbations of COPD?
Antibiotics work against bacteria. They are ineffective against viral infections. So run-of-the-mill chest colds, as you and I know well, are not indications for antibiotics. But in these folks, these exacerbations, even if they don't start with a bacterial component, often get complicated with a bacterial component. And therefore, multiple studies have shown that using antibiotics promptly in a COPD exacerbation can shorten the duration of the exacerbation and shorten the intensity of it as well. Sometimes in more severe exacerbations, we might add a short course of oral corticosteroids as well.
That's good to know. So what factors increase the risk of patients experiencing severe COPD exacerbations?
Yeah. Interestingly, the most important predictor of exacerbations is that you've already had one.
Right.
So what is it? Exacerbations predict future exacerbations. Clearly, exacerbations are correlated with the stage of COPD, but you can have nasty exacerbations in stage 2 disease. And so that's only part of the predictive equation. Again, I think the best way to identify someone at risk for exacerbation is to find out how frequently they've had exacerbations in the past. And these patients, I think, really need to be managed aggressively.
We've gone over this a little bit, but what current medications are available to improve lung function, overall lung function?
I think it's always good to sort of revisit and summarize, and but just to list the important ones that the GOLD guidelines recommend. Stepwise approach, short-acting beta agonists such as albuterol or ipratropium, then long-acting beta agonists. There are a number of these, salmeterol, formoterol come to mind, or long-acting anticholinergics such as tiotropium. And then the inhaled corticosteroids are next on the list, and examples would include budesonide, fluticasone, mometasone. These are the ones that have been shown in clinical trials to alleviate symptoms and make patients feel better.
Okay, so let's return to the case. So after 6 weeks, Ms. W returns to her clinic, and she has decreased her smoking to about 10 cigarettes a day. She thinks that she's getting better, but she's still short of breath when she goes to the gym. And now she's really motivated to quit. She's lost about 10 pounds and looks better than her previous visit. She uses her rescue inhaler less than once a day. She's not had any recent exacerbation. So should we repeat spirometry?
Yeah, she seems to be doing better. We need to get her off the cigarettes.
Yes, we do.
I'm glad she's at the gym, although I must admit I think the more structured format of a pulmonary rehab program is still a better idea. I'm not sure I want to add any more medications right now. She's using her rescue medications relatively infrequently, and I don't get a sense that we're dealing with exacerbations. We haven't discussed her oxygen status, but I'm going to assume that we've got that under control. So doing another spirometric measurement right now probably is not going to add a lot to what we're doing with her. I would save the spirometry for unexplained deterioration in her status.
Okay. So what non-pharmaceutical modalities are available to assist this patient? I mean, you've alluded to pulmonary rehab. Let's talk about that.
I'm glad you brought it up again because I like to reemphasize over and over and over again the importance of having not just pulmonary rehab in the exercise sense, but pulmonary rehab in the disease management sense. I think it's important that you and I partner with these patients so that they understand this often very bewildering array of medications, which ones are once a day, which ones are twice a day, which ones are rescue, how to deal with exacerbations, an action plan, if you will. So there are lots of non-pharmaceutical things that I think are appropriate to be used in these types of patients.
Okay. Is long-term steroid use a factor in light of her questionable osteoporosis?
Yeah, steroids would scare me in her. You point out very, very accurately that these patients, or our patient here, has osteoporosis, and this is actually very common. And so I would really try to stay away from steroids as much as possible. Maybe inhaled corticosteroids if she's moved all the way up the GOLD staging sequence and is still not well controlled. Maybe short bursts of corticosteroids during an acute exacerbation. But putting her on chronic oral corticosteroids would really, really scare me.
Patients know less about COPD than any other chronic condition. So what patient education should we discuss and institute in our patients with newly diagnosed COPD?
Yeah, Ben, that's really important. And you and I both mentioned it a couple of minutes ago. We need to partner with these patients. They need to understand not just how to take their particular medications, but they need to understand all aspects of their disease. What are things that actually might trigger an exacerbation? I mentioned that they get bacterial infections, but often something else starts it. So there's a whole host of educational things that need to be shared with these patients. We've touched on cigarette smoking and secondhand smoke. I think that's pretty clear, but staying away from contacts who might have infections. their grandkid who has a nasty upper respiratory infection. Air pollution can trigger exacerbations. Things like the need for oxygen need to be re-emphasized in those patients who do desaturate. Got to emphasize these patients to come back and see us and make sure we got things properly managed. Make sure they've got their annual immunizations up to date. And as I mentioned, make sure they've got an action plan to put into play when exacerbations start to crop up.
Okay, so we've covered all those things. So what are some of the emergent therapies that a primary care provider has at their disposal to assist in managing COPD patients?
Yeah, fortunately in this field there's some action going on. I mentioned briefly a little while ago, I'll re-emphasize it again here. I'm intrigued with this roflumilast, the phosphodiesterase inhibitor, PDE4 inhibitor, for the acute exacerbators. Now we got other medications that are known to reduce exacerbations. Long-acting antimuscarinics and inhaled corticosteroids are useful and have been shown in studies to reduce exacerbations. But if you've got a frequent flyer who you've got on what you think is an optimal regimen and they're still coming to you for prescriptions for antibiotics, prescriptions for short bursts of steroids, or visiting you in an emergency room, I think one needs to consider this as an additional option. There's also a very interesting study that was just published last year looking at daily use of azithromycin. Now, we've been using daily azithromycin in people with chronic airway disease like bronchiectasis and cystic fibrosis for years. It's intriguing that now an interesting study from the COPD network came out that said this might, and I underline the word might, it's just one study, but this might be another option in the frequent flyer, frequent exacerbator. In terms of other drugs, I don't think we're going to see any new drugs immediately, but I think what's coming out are going to be newer combination inhalers. We touched on this earlier. Patients get confused. There are a lot of things to take out there. And so combination medications that maybe we can take or prescribe for just once a day use could be very helpful. And there are some new long-acting antimuscarinic steroid combinations, once a day use. There are some new LAMA-LABA once a day use inhalers coming out that may make it easier for our patients to be compliant with their medications. And then in the most severe disease states, there's some interesting work going on in the surgical world. I touched on lung transplantation. That obviously has to be reserved for only major centers around the country. But there's another surgical procedure, lung volume reduction surgery, which is only for very specific types of emphysema, upper lobe predominance, severe disability, but taking out those overinflated regions in the top of the lung, reducing lung volume, actually allows the diaphragm to position itself in a better, more functional position, and can actually improve exercise tolerance and even mortality in the right group. So there's some interesting stuff going on in the surgical world as well.
Well, you've given us your thoughts on the bronchoscopic lung reduction. So is that only for the moderate to severe patients?
Well, actually, the bronchoscopic version of the surgery is even more interesting. Up over the last decade and a half, we've required a surgeon to go on and cut these hunks of lung out. Bronchoscopic is intriguing. Now you don't have to have a surgeon. What you do is you take a bronchoscope and you thread it up into the upper lobes, these overinflated regions. You put little valves in there. And this may be 6, 8, 10, 12 of these valves in the major airways of these overinflated upper lung regions, and they're one-way valves. So gas can't get in, but gas can get out. And there's a lot of interest in this approach. It's simpler than doing it the surgical way. Same physiology. You get these hyperinflated regions to collapse, the diaphragm moves up. Does it work? Does it work? Well, we're still not sure. I get concerned when you put little valves in airways that we're going to end up with post-obstructive pneumonias.
I was thinking the same thing.
So yeah, so the jury's still out on these rather novel techniques. But I think it's exciting that we're exploring outside the box for managing these patients with COPD.